All right. Hi, guys. Good evening, all of you. So, can we start the discussion? So, today is NEURO-OPHTHAL quiz discussion. And now, before we start the discussion, those of you who have missed the discussion, you can always take the link. You can click on the link which I've given in the video description. You can go there and take the leaderboard quiz. Good evening, Vinod. Good evening, BU. Vanakkam, vanakkam. So let's start. So the first question is treatment of choice for arteritic AION. So for newbies, what is AION? Anterior ischemic optic neuropathy. Okay, optic nerve is ischemic, the anterior portion of the optic nerve. So that is the optic disc is ischemic. Now why is it ischemic? Because its blood supply is reduced. Yes. Okay. Now, arteritic AION. What is the most common cause of arteritic AION? What is the most common cause? Then from that, we can arrive at the treatment of choice. Yes, what is the most common cause of arteritic AION? Because my question today is, what is the treatment of choice for arteritic AION? So, what is the most common cause of arteritic AION? Very good, very good. Giant cell arteritis, GCA. Yes, you know giant cell arteritis affects the large vessels. Yes, so the large to medium sized vessels. Yeah, so the short posterior ciliary artery, the SPCA, that is supplying the optic nerve, the intraocular portion of the optic nerve especially, is affected by this arteritis, giant cell arteritis, GCA. Now, if I have an inflammation like that, what would be my treatment of choice? Let's look at the options: oral NSAIDs, IV mannitol, levodopa, carbidopa, systemic steroids. So what can we rule out? See, I have an inflammation, arteritis. The artery is inflamed. Yeah. Now, oral NSAIDs maybe, but anyway, let's keep it under option. Okay. So I'm talking about those who have no idea at all. For you, it's clueless, like some of you are my new bache who joined and just watching it, you have no idea about NEURO-OPHTHAL at all. All that you know is arteritic AION. And now that I've told you giant cell arteritis is the most common cause of arteritic AION, that is AAION. You know about GCA, you've learned it in your pathology, you're new to ophthalmology, that's it, right? Now option A, oral NSAIDs, let's keep it for revisiting. Intravenous mannitol and inflammation, I don't think anything to do with it. So I can safely kind of rule out IV mannitol, which is option B. Option C, levodopa, carbidopa. Now, if you don't know anything, you can easily rule it out. If you know something about AION, you may get confused and still keep it in your option. But now, assuming we don't know anything, we'll rule it out. Okay. I'll tell you why it can cause a confusion. I'll tell you later. Options D, systemic steroids. Now, oral NSAID, systemic steroids. Now, you want it to reach your arteries and better than oral NSAIDs. And you know what is the treatment of choice for giant cell arteritis. You already probably learned it in pathology, when you learned about giant cell arteritis. So, treatment of choice is systemic steroids. Okay. So, for both for giant cell arteritis and also for the arteritic AION, it is systemic steroids. Now, so definitely not oral NSAIDs. We're not going to give oral NSAIDs. I'm going to give systemic steroids. Why? Because if one eye has arteritic AION, it is an ophthalmic emergency for the other eye. Because I don't want this GCA to affect the other eye optic nerve's blood supply. So to protect my other eye, because already this visual prognosis is very poor. Okay, very poor. So I don't want the patient to suffer from another attack in the other eye. Yeah, because otherwise he'll become bilaterally blind. Yeah, so to protect the other eye, you have to give systemic steroids. Yes, so that is the treatment of choice. Don't wait for the investigation, your temporal artery biopsy. Don't wait for anything. Start the steroids. Yes, start the steroids because this is an emergency. So you will put the patient on the first 3 days, you will put him or her on intravenous methylprednisolone, and the next 11 days on oral prednisolone. Okay, the same dosage that we gave for optic neuritis. Okay, so same 3 plus 11. Okay, so that is what we're going to give for arteritic AION. Is that clear? Okay. Now, What is the role of this levodopa-carbidopa? No role in arteritic AION. You can try it in non-arteritic AION. Now again, in non-arteritic AION also, the visual prognosis is still poor in non-arteritic. But yes, levodopa-carbidopa, in clinical trials it has been tried, and yes, to a certain extent it kind of helps. So that's the only thing. Again, it is not treatment of choice for anything at all. Is that clear? All right. So question number 2. Which of the following is affected in optic neuritis? So it is like I've given 4 facts, and the options are a combination of these 4 choices. Yeah. So visual acuity. Is visual acuity affected in optic neuritis? Yes. There is a sudden, profound and progressive decrease in vision. Vision means visual acuity. It is definitely decreased. Yes. So 1 is affected. What is number 2? Color vision. Yes. The red color is first affected even before visual acuity, actually. What we call a red desaturation. The red color appears washed out. Yeah, red desaturation that occurs. Option 3. Contrast sensitivity. Yes, contrast sensitivity is decreased, and in fact the color vision and the contrast sensitivity, the decrease that happens, does not recover as much as visual acuity does. So there is a persistent decrease. It persists even after the optic neuritis recovers and the visual acuity recovers. This हमेशा के लिए कम रह जाता है. Okay. So yes, what about the 4th one? Pupillary light reflex. Yes, of course, that is the hallmark sign or the earliest sign, RAPD, relative afferent pupillary defect, because my optic nerve, which is the afferent for the pupillary light reflex, is abnormal. What we call Marcus gun pupil, especially if it is a unilateral optic neuritis. So that also is affected. So 1, 2, 3, 4. Yeah. Yes, we say red green. Yes, red green. But to be very specific, it is red. To be very specific and very early is a red color deficit. Okay, red color desaturation. Generally in optic nerve problems, we have a red-green color problem. Okay. So 1, 2, 3 and 4 all. Because I had given combinations of 1, 2, 3 and 4, 1 and 4, 1, 2 and 3, 1, 2 and 4. So the answer is, right answer is 1, 2, 3 and 4. Now the next question, scanning of visual field is done by which lobe of the brain? This was actually from the IMI-CT November 2025 question. So the visual field, the scanning is done by frontal lobe. Okay, the scanning is done by frontal lobe. It's because you have to quickly, that is basically what is the scanning? See, basically what they wanted to ask was saccades. So saccades, where is the origin? Saccades is from the frontal eye field. You remember I've taught you frontal eye field. Yes. So that is the generator of saccades, because you have to quickly see, scan. Yes. See, when you talk about, this is a beautiful question. Okay. This is a beautiful question. Actually, it's based on evolution. Yes, it's based on evolution. Because if you have to scan the visual field, you have to do rapid eye movements. I cannot be like a sloth and say, I will scan. No, you have to quickly scan, because you have to protect yourself. See, those days, nowadays, everything is, you take the phone. You want food? Order on phone. You want clothes? Order on phone. You want madam's notes? Order on phone. You want anything? And if you have any doubt, you will not open your textbook and read also. You will not get up from your place, go search for a textbook, bring that textbook and search. No. Rajarathna madam in Google auntie is there. I will text her. Everybody knows her WhatsApp number. Madam, how many eyes we have? You won't even give me options. Okay, because you haven't read anything. You saw some question on eye. Ma'am, how many kitne aanke hain? Usko WhatsApp kar do. ठीक है? Okay. So we become like that. But earlier, we had to save ourselves, because we had so many predators. So I will, like a deer, when there's a lion chasing, the deer has to run away. So if the deer has to run away, you have to scan quickly. So quick movements are your saccades. So where are the saccades initiated? The saccades come from the The origin is your frontal eye field. Yes, your frontal eye field. So frontal lobe, that was a basic thing. So if you know this commonsensical thing and you already know where your saccad's origin is from, then you know the scanning of visual field. You know, it was just a different way of putting it. Vinod, did you understand the concept? There's no question of why not occipital lobe. That question doesn't even come. You understand? We're not talking about vision here. I have to scan. कितना जल्दी मैं देख सकूं ताकि मैं भाग जाऊं यहाँ से, वरना कोई मुझे खा लेगा ना. யாரா சாப்பிட்டுருவாங்களே என்ன, அதுக்கு முன்னாடி நான் குடு குடு குடுன்னு ஓடணுமா வேணாமா, மான் மாதிரி துள்ளி குதிச்சு ஓடணும்னா I need to scan, right? I need to know where, which direction are my enemies, which direction is a danger. So I need to go. Got it? All right. Never forget it. Okay. So now you know which lobe is. Actually, I love this question when I saw this question, you know. So rather than asking you directly where is the origin of saccades, probably if they had asked you that question, you could have answered it from my OPHTHAL notes or from your physiology, if at all you had read your textbooks. It's there in Gelong. So based on that, or saccades, if they ask directly next time, or if they ask a question like this. All right. Okay. So let's move to the next question. All of the following are true regarding papilledema except. So we need to find out the false statement. Yeah. Option A, bilateral. Bilateral is true because that is the definition of papilledema. See, papilla means optic disc, that is the intraocular portion of your optic nerve, and edema. Okay, actually that term edema is a misnomer. There's no edema as such. There is axoplasmic stasis. Okay, there's axoplasmic stasis. So that also was a previous year question. So if they ask you papilledema is an inflammatory disc edema, it's an axoplasmic stasis, extracellular edema, it is axoplasmic stasis. Okay, so it is not edema in the real sense. It's a misnomer. All right. So the definition of papilledema, two parts to the definition. One, it is bilateral disc edema. So there is bilaterality in the definition. Number two, secondary to a raised ICT, when you have a raised intracranial pressure, because of that, when you get bilateral disc edema, that is papilledema. Is that clear? Okay. So option A is true. Option A says bilateral. Option B, consecutive optic atrophy. See, if you know the definition of the different types of optic atrophy, this is very, very simple. Secondary optic atrophy means an optic atrophy that occurs after disc edema. So if my papilledema is not treated, what do you do for treatment of papilledema? You'll have to you have to decrease the raised ICT. You have to do some measures. Yeah, give acetazolamide, IV mannitol, whatever. So once you decrease the ICT, the papilledema is going to resolve. Now, if that was not done on time, then the ganglion cells are going to die, the axons are going to die, we're going to get optic atrophy. What type of optic atrophy? Secondary optic atrophy. Because what is the definition of secondary optic atrophy? Optic atrophy that occurs after disc edema. So now if I know the definition of secondary optic atrophy and I know the definition of papilledema, I could have simply arrived the answer that this is a false statement. Consecutive optic atrophy does not happen here. Consecutive optic atrophy means after a retinal disease, an extensive retinal pathology or a disease, something, degeneration, if there is an optic atrophy, that is consecutive optic atrophy. Is that clear? Okay. So we already arrived at the answer, but anyway, let's learn. Let's look at option C. Pupil is normal. Yes. Pupil is absolutely normal in papilledema. It's neither sluggishly reacting nor is there any RAPD, nothing. It will briskly react to light. Okay. Nor is the size abnormal, nothing. Everything, size, reaction, shape, everything is normal in papilledema. Cup is obliterated. Yes, when you have axoplasmic stasis, it fills the cup. So there's no more cup. Cup is filled. Cup is obliterated. Gone. Gayab. Okay, move to the next question. Internuclear ophthalmoplegia, INO. INO is due to lesion of. I am not going to explain INO here. At the end of the session, in the comment section, I will put the link to the INO where I've explained INO. Okay, I've explained under 2 minutes. I guess 2 minutes or 3 minutes. Okay, just spare 2 minutes of your time and watch that video. I'll share the link at the end. We'll not do that now. So INO is due to lesion of MLF, medial longitudinal fasciculus. Okay, ipsilateral MLF. Yes, it's very interesting, and I've made it very interesting. I've demonstrated it to you. You'll never forget it. Okay, so medial longitudinal fasciculus. Pretectal, option A, pretectal nucleus is the center for pupillary light reflex. Nothing to do with INO. Edinger-Westphal nucleus, that is parasympathetic subnucleus of third nerve, and it's an internucleus in case of, is an in-between nucleus in case of pupillary light reflex. Abducens nucleus is there in the pathway, in the gaze pathway, but it's not there in, nothing to do with INO. INO is medial longitudinal fasciculus lesion. Okay. Convergence, retraction, nystagmus. So when you ask give the patient a near target, okay, some near object, you know, near triad or accommodation triad is going to start working now, and both the eyeballs are going to converge. So when there is convergence, the upper lid will retract, and also there will be a nystagmus. That is called convergence, retraction, nystagmus. Okay. So on when you give a near target or an accommodation target, it's typically called a near target, there is convergence, there's a retraction, abnormal retraction, and nystagmus. Convergence, on convergence is a retraction and nystagmus. So that is seen in Parinaud's dorsal midbrain syndrome. Okay, it is seen in Parinaud's dorsal midbrain syndrome. Yeah, I'll come to it. 1 second, BU. What about option B? So already we got the answer in option A. Option B, Weber syndrome, I will talk about it in a little while. Webino syndrome is bilateral INO. Bilateral INO is Webino, INO meaning internuclear ophthalmoplegia. So Webino, W-E-B-I-N-O, W, wall, E, eyed, wall-eyed, B, bilateral, INO. Wall-eyed, bilateral, internuclear ophthalmoplegia. That is Webino syndrome. Now, the most common cause of both INO and Webino is multiple sclerosis. Why? Multiple sclerosis is a demyelinating disease. And what is this medial longitudinal fasciculus? It's a white matter tract in the brain. So, any demyelinating disease is going to affect the white matter. So that is why it's going to, multiple sclerosis is going to affect your medial longitudinal fasciculus, which is a white matter column. That is why multiple sclerosis is the most common cause of INO and Webino syndrome. Is that clear? All right. What is next? Juxtapapillary telangiectasia. See, only one diagnosis when you come across this juxtapapillary telangiectasia at your level. Okay. Juxtapapillary means, papilla means optic disc. Juxta means adjacent, next to it, around it. So around the optic disc, when you see dilated and tortuous vessels, telangiectasias. Juxtapapillary telangiectasia is characteristic of Leber's hereditary optic neuropathy, LHON. Okay. So in Leber's hereditary optic neuropathy, there's no itis there. Neuropathy, there's no inflammation at all. So there, yes, you get juxtapapillary telangiectasia, and it is characterized by 3 M's. 3M. What are these 3 M's? It's a mitochondrial mutation. Okay, underlying thing is a mitochondrial mutation. You know, mitochondria are inherited maternally. So it's a mitochondrial mutation. So maternal transmission. So mitochondrial mutation, so mitochondrial inheritance. And mitochondrial inheritance is through the mother. So transmission is through the mother. Maternal transmission. And males are the one who are usually affected. Okay, so these are the 3 M's of LON that you need to remember. Okay. What are the other options? Idiopathic intracranial hypertension, we'll discuss on another day, nothing to do with juxtapapillary telangiectasia. Caroticocavernous fistula, you will get episcleral vessels, corkscrew episcleral vessels, nothing in the fundus as something like this. You might get dilated and tortuous veins, but that is not described as, given this terminology as juxtapapillary telangiectasia. Okay. Posterior ischemic optic neuropathy, which is not discussed at your level generally. PION. PION is something where the fundus will be absolutely normal. Okay. PION is absolute normal fundus. Yeah. But yes, the pupillary light reflex will be abnormal, but the fundus absolutely normal, because posterior, it's posterior to the lamina cribrosa. So what you see on the fundus is your optic disc, which is anterior to the lamina cribrosa. That will be absolutely fine. Okay. What were you saying? What's Coates disease? Which is Coates disease? No, I didn't get you. Coates disease, there is no telangiectasias as juxtapapillary telangiectasia. No, we do get microaneurysms. There can be telangiectasias in the posterior pole, but that is not described as this juxtapapillary telangiectasia. See, Coates disease, you can get microaneurysms in those telangiectatic vessels. Yes, very detailed description they're giving about Coates disease. Yes, they can give telangiectasias in the posterior pole with microaneurysms, which are typically described as light bulb aneurysms. Okay, and you will have a lot of hard exudates and serous retinal detachment, Coates disease. So because the massive intraretinal exudates, that is why you get this leukocoria in Coates disease, not here. Okay. Now the next question is ipsilateral third nerve palsy and contralateral tremors. That means one of the syndromes associated with third nerve palsy we're going to talk about. Now, ipsilateral third nerve palsy and contralateral tremors seen in, let's look at option A. Option A is Weber syndrome. See, Weber syndrome is the problem or the lesion is at cerebral peduncle. And what is there in the cerebral peduncle? Cerebral peduncle, we have pyramidal tracts. Yes, pyramidal tracts. So you will get a contralateral hemiplegia. Ipsilateral TNP, third nerve palsy, but contralateral hemiplegia, Weber syndrome. Option B, North-Nagel syndrome, the lesion is at superior cerebellar peduncle. I'll teach you in a different class in detail. So North-Nagel syndrome, you'll get ipsilateral third nerve palsy and ipsilateral cerebellar symptoms. So probably ataxia and stuff like that, pass pointing and all that. This kind, what do you call that? Dysdiode. I forgot the name. All right. So all the cerebellar features you'll get on the same side, both third nerve palsy and this, because of the double decussation that occurs with the cerebellar fibers. Option C, Benedict syndrome. Benedict syndrome is the answer, where the lesion is in the red nucleus, because the third nerve fascicles will pass through the red nucleus. So that is why you'll have ipsilateral third nerve palsy and contralateral tremors, all these extrapyramidal tract symptoms, this tremors and all you'll have. So that is Benedict syndrome. Yeah. Foveal syndrome is not at all related to third nerve. That we'll discuss on another day. Okay. Foveal is not at all related to third nerve. That you keep in mind. Dysdiadokinesia. Yeah. Thank you, BU. Yes. Thank you, Vinod. All right. Now next one, pie on the floor visual field defect. Very, very simple. Pie on the floor, we are talking about an inferior quadrant anopia. Pie on the floor when you have a parietal lobe lesion. Yes, parietal lobe lesion affecting the superior fibers of your optic radiations. What do we call the superior fibers of the optic radiations passing through the parietal lobe? They are called Baum's loop. Okay, BAUM. So that's why I always tell you, remember the SPB. Not the SPB, remember SPB. The that old Meyer's loop is temporal lobe. Parietal lobe is Baum's loop. SPB, superior fibers, parietal lobe, Baum's loop. So SP Balasubramaniam, everybody knows, at least all Indians know. If you don't know, again, North Indians, you know the Bahujan Samaj Party, BSP. Yeah. So Baum, superior, parietal. Yes, Baum, superior, parietal. Yes. So in that case, you get a pie on the floor, one pie, like 1/4 of a circle. So quadrant anopia, inferior quadrant anopia, and it would be a homonymous contralateral homonymous inferior quadrant anopia. Is that clear? So pie in the sky, you'll get pie in the sky in temporal lobe lesion. Yeah. So temporal lobe lesion or your Meyers's loop. Okay. So that is your inferior fibers passing through Meyers's loop. All right. Last question. Toxic optic neuropathy may occur due to all except. Option A. Option A. Isoniazid. Yes, isoniazid. We do get toxic optic neuropathy. Yes, typically we used to get in ethambutol, also gotten in isoniazid. Option B, linezolid. I discussed in a previous, I think yesterday or some retina quiz, I think I had one question for you regarding some maculopathy or something, macular edema or something. Oh no, yeah, glaucoma drugs. Yesterday's quiz we discussed, and at that time there was an option called linezolid or something. Then I said no, linezolid causes toxic optic neuropathy. It doesn't cause macular edema. So if you had listened to me very carefully, you would have never marked linezolid, because I am asking you all except. Yeah. Toxic optic neuropathy may occur due to all except. Isoniazid, yes, causes. Linezolid, yes, it causes. Amiodarone, yes, of course it causes. What about option D, vigabatrin? Vigabatrin does not cause toxic optic neuropathy, but it affects the it affects the retina in such a way that there is a constriction of the visual field. So when you do a perimetry, there is a constriction of the visual field. So patient does not see the periphery. Okay, periphery it affects. So there is a constriction of visual field that occurs with vigabatrin. All right. So have we covered all the 10 questions of neuro-OPHTHAL? BU, now ethambutol is not there in the new regimen. The government has taken off ethambutol. They've replaced it with moxifloxacin. No, so now no problem at all. So I'm sure unless somebody who has not updated and taken it from some old Q bank, only then there's a possibility of even ethambutol being under the options. Otherwise, no more ethambutol in antitubercular treatment. Why else would you give ethambutol? So read up about your new ATT guidelines. Okay, antitubercular treatment guidelines does not have ethambutol anymore. Yeah. Okay, so we'll wind up. Tomorrow is orbit and trauma quiz. So 6 p.m. on the that also I have a nice video. I'll put it for you. 2 minutes we've discussed. Okay, ethambutol toxicity I've made. I'll share that link also. You watch that. Okay. I'm not going to talk about that because now we are in latest 2025 December. Now 2026 is going to dawn in another 20 days. Why talk about old stuff? No. What was I saying? Yeah, orbit and trauma quiz tomorrow. And those of you who missed the neuro-OPHTHAL quiz, last year, I'm so sorry. Yeah, so the link for the leaderboard quiz, the free leaderboard quiz is given in the video description. You can take that quiz. So you get a leaderboard, you know your ranks. All right, so I will see you tomorrow. And today there was an OPHTHAL image-based question. It's an instrument. Go and look up the Instagram, my Instagram too. I'll share that link as well in the comments. So go and see that because that was something that I taught you yesterday. So I thought I'll give you the same kind of, a similar kind of image for you today to deal with. Okay. So we'll discuss that image probably sometime tomorrow or the day after. I'll share the updated timing tomorrow. Okay, 9 p.m. quiz discussion definitely about the image discussions. I will update you. All right. Okay. See you, bache. Bye bye. Good night.